Okay, James, thank you very much. I've been told, and this applies to all the other speakers in this session, to hold this by your chin. That means that I've got an extremely distorted sound of my own voice, but do wave if you can't hear me. This is a real speed session, this first one. It's going to provide an overview, and then the questions are going to be what else should we be celebrating, what's been done that doesn't work, and what needs to be done in the future. So those will be the exam questions. We only got 6 or 7 minutes per speaker. I hope I'm not the first one to break the rule by going on for too long. I'm just going to give a very brief overview around the infrastructure and the support for care research that's really been going on right from the start with Dendron back in 2006 and through now, as James says, to planning for the 2025 strategy. The next slide, I'm grateful to James for having provided, because I think it shows very nicely that although care research has been somewhat of a Cinderella subject, in the UK, we really do punch above our weight. This is a look from 2016 by the JPND, sorry, I ought to know that. Spending so much time with it, JPND, that when one looks at the proportion of care research that's done, the UK is far ahead in Europe, and importantly, when you look at now the G7, and that's important because of the 2013 G8 as then summit around dementia, is again, the UK leads in terms of the proportion of its research spend that's on care research. And the JPND did a further analysis last year, and if one just looks, sorry, I don't have a pointer, yeah, just down here, one can see that research has increased between 2016 and 2019, and that does include also health and social care research, but it is still lagging behind. Just a couple of comments about some of the infrastructure that can support care research. The Enrich network enabling research in care homes was started by Dendron in response to the fact that although a lot of care research would take place in the community and at homes, to do it in care homes was extremely difficult, not least to issues around service support costs, etc. And so a network was set up called Enrich that has provided the infrastructure for care home research. And I think Adam Gordon will also briefly refer to that in his talk. Joint Dementia Research, the dating agency for patients and researchers, now has supported about 25,000 people entering research. It's difficult to judge how many of that is care research, but it's probably about 20%. The reason why I think that's important is because of the necessary criteria for supporting research. A lot of research that's done at undergraduate level and at PhD, master's level, is off the radar. And my impression, it's only an impression, is a lot of that is in the care research area. So about 20% people can find individuals to engage in care research. The other thing is bringing young people into the game, and the Dementia Portfolio Development Group, which has been run through the National Office, the major proportion of that is in fact in care research, and it's been bringing people in to support and provide writing groups. And they've been the main users of this facility. And still on the theme of young researchers is the Dementia Researcher website that Adam Smith set up. Adam will be going around interviewing a lot of you today, and his right sitting there is actually crouching down so that he can't be seen on table 1. But this has over 1,000 subscribers, and again, the main contributors are in the healthcare research to many of the blogs. So I'll finish there and hand over. And while Alistair is not here, well, that's great. So we've all agreed, I think, in the room that more NHS England spending will go on to care research. Thank you very much, Alistair. We'll let you know that when you arrive. So maybe while Barbara's coming up to speak, just in terms of what's missing, I'll take a personal comment. I think what's missing is a really rapid assessment of a lot of care research interventions, and I would suggest we need an adaptive trial platform that you've got in cancer. Pharmaceutical interventions, we need it for care research interventions. Barbara, over to you. Remember, it's the chin against the microphone.
Yes. Like James, I feel a little wobbly standing in front of this group. I am in awe of the expertise in this room. I had a mother who had dementia. I have had many relatives, I have colleagues that I've worked with, and I have friends. So many people with dementia, and in the time that I have been involved, I have seen such changes. Most of you will know that the Alzheimer Society was set up in 1979, so it was 40 years old last year, and I think its achievements in that time are amazing. The research network was set up 20 years after that, so last year it was 20 years old, and it began when a group of people in the society and researchers felt that actually they really needed the voice of people with dementia and the voice of people who cared for with dementia. And I'm very fortunate because I was one of the very earliest people in that group. I saw a little advert in one of the documents that the Alzheimer Society sent out asking for people who had been affected by dementia, either with dementia or as someone caring for someone or who had cared for someone. And I thought, gosh, I've learned so much because my mother's had dementia. I know quite a lot about the health service, hospitals, all the people that get involved, and not least charities. So I thought, yes, that really appeals to me. I would like to do that. And so I did begin at the beginning with about 100 other people. And I would just say now there are nearly 400 people who are research network volunteers, which is quite impressive. And obviously, it's many, many, many more than that over the years because people have come and gone for a variety of reasons. In those days, it was very simple. We were told we would be researching into cause, cure, care, and prevention. And today, I know we're concentrating on care. Research network people have a very active role, but it's very flexible. We are required, as far as we possibly can, to look at applications for funding, comment on them, grade them, and say what we honestly think. And that's all we are expected to do. But I think an interesting word in relation to the research network is evolution, because over time, what we do has evolved. Increasingly, we are being part of applications, we are on grant panels, we are on steering groups, and we do talks and we campaign. So our role has grown, but there is no pressure to do that. So we are all people who are happy to be doing it. It's not our living, we have other lives, but it's an important, significant part of who we are. So our roles have expanded over the years. And I would just add, as has been said already, some of the initiatives that have gone through this time. The National Dementia Strategy, the Challenge on Dementia, Ministerial Advisory Groups on Dementia, and the G8 Summit. I'm not going to say anything more about those, but they're really huge things. And the researchers, what have they been doing? Well, again, I can only indicate a small number. Drug discovery, drug repositioning, the doctoral training centres. And I hope some of you won't mind if I say this was an initiative, because some of you are getting older and we fear losing you. And so the Doctoral Training Centre are hopefully training people to become researchers of the future. And many of them are coming to an end this year and have got some really good and interesting results. Interestingly, earlier diagnosis and what that means, and timely diagnosis, as some people now call it. And lastly, a really interesting thing has been the identification with people with early onset dementia in their 40s, in their 50s. And they are actually an incredibly active voice saying what it's like to have dementia at that age. And they're really quite a power group. So many things have changed. Also, the collaboration for us is interesting. You know, the Department of Health, the Medical Research Council, the National Institute for Health Research, and of course the charities. And what has been done during that time? Sorry, I find this very difficult. Sorry, I want to tell you about 3 or 4 conversations I've had recently, and I absolutely know that we shouldn't extrapolate from the particular to the general, but nevertheless, I'm sort of going to do that. The first thing I heard recently, I found extraordinarily sad, extraordinarily poignant. An ex-carer said to me, her mother had a very, very difficult time as her dementia progressed, and her mantra became, God has forgotten me. And I think that in our joint resolves here to make life better for people with dementia and their carers, we have to make sure that no one is forgotten, because I think there are pockets where people are forgotten. So that's what I would first of all say. Secondly, I was talking to someone recently whose mother-in-law has just died after a very, very long time in a care home. And she said she was really, really upset by the fact that though she'd been on a very good project talking about care, though the staff were kind and compassionate, the management never spoke to her or her family either before or after this was happening. And the third thing, really, I would want to say is that we're really good on measures, but there are lots of measures we can't do. And my cousin, whose mother had Alzheimer's and has recently died, said to me, because she looked after her mother at home for 20 years, she said to me, you know, Barbara, I would never have survived without the Alzheimer's Society online information. She said, I kept going on and I got information and I could use it and it gave me power. And lastly, when my mother was in hospital towards the end of her life, it was really, really dreadful what I saw there. It was so bad. I did actually go and see, after she died, and thankfully she didn't die in the hospital, the director of nursing, who said there is a culture on that ward of neglect. Fast forward a little bit, and my husband was in that same hospital, and we were in there day and night, and he was receiving palliative care, nothing to do with dementia, another condition. But the way they were treating people with dementia when there were problems was hugely impressive. And he kept saying, you know, I'm really impressed, you're so good, what are you doing? And they all said without fail, we've been trained. And they would say they would have a difficult situation, they'd think back to what they'd learned. And so there was implementation there. And my great thing is that you are all brilliant at dissemination. You are not so good at implementing, and that's because that's not your job. So I think the big challenge for us, Martin, is that we need to get on to really implementing so that it doesn't just make a difference to the few, but to the many. And I think we've got to really agitate the government to do this. Thank you.
Jill. Thank you. Assume Alistair's not here.
Yeah, but we get.
I'll look at it.
Okay, I'll keep an eye on your agitation. Hi. Thank you for inviting me to talk. I've been told to talk about START, which stands for Strategies for Relatives, as an example of a trial. This is study that we did many years ago, but we just published the 6-year follow-up of it, and it's an ongoing study which we are to follow on Barbara, working with the Alzheimer Society on wider implementation. And it's been done with colleagues, some of who are here in the room, like Martin Knapp, who's over there, and Claudia Cooper, who's down there. So we all know, that there are many, many people with dementia, and the numbers are increasing, with roughly about 810,000 here, most of whom are looked after at home, with their primary carers being people in the family or friends. And it's very difficult to look after somebody with dementia. 40% of family carers have clinically significant depression or anxiety, and other people have symptoms which get in the way of their life. The symptoms predict care home admission, because if you're depressed, you can't really look after somebody. More abusive behaviour, it's more difficult to control yourself when things are difficult. And carers often feel very bad about all of this, which is not how they plan their life. Nobody gets married saying, well, what I'm going to do is get angry with my husband or my wife and then put them into a care home, but that's how it often happens. Care at home by relatives also saves a considerable amount of public money, and the part of the UK strategy is it should continue to mainly be done by family. So not only is there a medical, but there is also an economic and policy imperative to look after them. So what START is it's a UK manual-based therapy for dementia carers. And the point of putting it in a manual is that it can be delivered consistently. It used trained, supervised graduates without clinical qualifications, and that means it uses people who are available and relatively cheap. It's delivered to individuals, as problems are very different between people and often sensitive. People often can't talk about them in a group, and it allows flexibility in timing, because if you say to people, you've got to come every Tuesday evening to a group at 8 p.m, very many people can't come. And it's 8 sessions. These are the sessions, but I don't have many minutes. I'm not going to go through them. But basically, it involves understanding about dementia, and there's some messages in it that it's important to look after yourself, or you won't be able to look after anyone else. That it's that the person with dementia cannot change their behaviour. You have to change or help them. You can't just tell them to be different. That they're not doing it on purpose. That people, even if somebody else in the family can't do all the looking after, they can perhaps do a little. It's not all or nothing. How you can communicate, how you can plan for the future, how you can relax and cope. And it's all based around the idea that different coping strategies make a difference to the outcome. It doesn't make any difference to the people having dementia, but it changes the outcome. So we did an RCT, which was funded by HTA and IHR, of 260 people, and basically it worked. So the people in the intervention group had about a fifth of the rate of depression compared to the people in the non-intervention group. They had a better quality of life, and it was cost-effective. At 8 months, it was cost neutral, because although it cost money for the carer, it saved money on both carer and the person with dementia's costs. We didn't know it would do that, because we suggested people ask for help when they needed it, but maybe they needed less help. A 6-year follow-up found that the depression rates in the intervention groups remained at 20% of the treatment as usual, and that the costs for the person with dementia in the intervention group was much less than for the person in the non-intervention group. They lived more months at home, which was not statistically significant, but probably another 5 months makes a difference to families. And there was no significant group difference in time to care admission, but there was a tendency for it to take longer. So I think there were some messages from this. We did a theory-driven intervention We did a randomized controlled trial with blinded outcome, and we kept following it up to give a message that it continues to work over time. I don't have time to tell you about it. We also did a qualitative part of the study to ask people what they use, and different people use different bits of the intervention. And I think that when you do a quantitative study, qualitative is also important. The US government task force in November 2019 have done a meta-analysis and systematic review of all carer interventions. According to them, there are only 6 good quality RCTs, which fortunately included START, or I probably wouldn't tell you. Only 4 of them were full studies, 2 were pilot, and only 1 of these 4 studies worked, and that was START. Overall, they did the meta-analysis of all the RCTs, and it made no difference. So I think there's a big message that if you keep using non-evidence-based carer interventions, carers will probably like it, but it probably won't make any difference to their mood or their quality of life. So we talk about cost effectiveness. If it's not effective, it can't be cost effective. We're doing an AS-funded implementation study to make it more widely available, and it's been successfully delivered by some dementia support workers, and we've also made it more ethnically tailored. So summary, it works, it's cost effective, it potentially saves money. I think we should use it. We're trying to work on implementation. I've also met with people in our local art to talk about it. We're making it available in different languages and trying it over the world. It's potentially transformative for carers. And I think that we should be working on theory-driven interventions and do quantitative and qualitative follow-up to try and see if they work. Thanks for your attention.
Yeah, I don't think Alistair's arrived, so...
Okay. He's going to arrive in a blaze of glory just at the conclusion. Yeah. Okay, so I'm nervous about speaking to this audience for another reason, which is, as a geriatrician that doesn't ostensibly do a lot of primarily dementia research, I feel like a bit of an interloper and an imposter. But as I was sort of preparing the talk, I was reminded of this really helpful diagram that comes from work by Bruce Guthrie, published in the BMJ in 2012, and it's about comorbidity and common long-term medical conditions. And if you look across the bottom, the percentage of people that have dementia that only have dementia and not another long-term condition is 5.3. So actually most people with dementia have a lot of other things going on in their lives as well. And that I thought, well, that gave me a position of legitimacy from which to start speaking to you. I've been ostensibly asked to speak to you about care homes and the role of dementia research in care homes. And I thought, how can I possibly talk about that in a meaningful way in 7 minutes? I might want to talk about the MARC study, I might want to talk about the OPERA study, and I got excited about all the things I could possibly tell you, and then I realized that that would be a 1-hour keynote, and so instead I decided that what I would do is I'd be parochial. I thought this was an interesting quote: art must be parochial at the beginning to be cosmopolitan at the end, and I'd start by reflecting upon my own experience. I did Google George A. Moore, by the way, and he's not a dodgy geezer. He is in fact a poet and philosopher, so I thought I could safely quote him at the outset of this brief talk. So what I thought I'd do is I'd reflect upon 3 studies that we've done or participated in the East Midlands where I work, talk about some overarching lessons that come from them, and then round up by talking about a few bits of infrastructure, including Enrich, which has helped and enabled us to do those pieces of work. The first thing I want to talk about is this thing here called the Optimal Study. It was in fact led by Claire Goodman, who's pictured in the top right-hand corner from the University of Hertfordshire, but it was a multi-centre study involving 5 universities in 3 different parts of the UK, taking a realist approach to understanding how older people living in care home use NHS resources and what is the best and most effective way of delivering care for them. I wanted to highlight this for 2 reasons, because one of the successes that that we need to celebrate in care home research is it has very quickly and rapidly, as a Cinderella area, become collaborative and multi-centre. Most of the good work that's happening now in care home research is very collaborative and multi-centre. And I think that speaks to two things. One is that to understand the care home context, you need to work in multiple parts of the UK. And the other thing is that the expertise to do this type of research isn't located in one centre. So my encouragement is to reach out and to form connections. But the other important piece of about this work, which was an extensive piece of work, 218 residents follow for 12 months with all their NHS resource use and a further 118 interviews with staff that were caring for them, was that it didn't ostensibly set out to be about dementia, but one of the largest themes that came out about it was about dementia. Effective care was only effective if the dementia care component of that was well delivered and well thought out. Effective services were services that could effectively both engage with residents with dementia, but also link in and engage in a cross-linking way with dementia services. So this is another overarching thing about care home research. Even when we set out to do research that's not about dementia, we come straight back around to dementia again. And that was an important sort of overarching point that I wanted to take out of that. Which brought me on to another example, which is the PEACH study funded by the Dunhill Medical Trust. We've recently finished that in the East Midlands, and I wanted to pick two pieces out about this. This was a quality improvement collaborative study, so we were studying how to do quality improvement collaboratives to deliver better comprehensive care to older people living in care homes. And again, it was multi-centre, again, it was collaborative, but again, it accidentally stumbled into the field of dementia. So we had 4 separate CCGs across South Nottinghamshire. We allowed them to do whatever they wanted to do to improve comprehensive care for older people, and in one centre that became ostensibly about dementia. It was led by the community mental health team. They stood up as the people that knew the most about care homes and the most about care home residents, and they structured their intervention around dementia. The other thing about this is it shows how fertile the NHS is becoming with regards to doing collaborative work around care homes. These were quality improvement collaboratives. They were staffed entirely by NHS staff who were doing this in addition to their day job and forging on in order to do this. And for someone like me who's been working in care home research for a decade, it's quite interesting now to see how when I go to the NHS, they're ready to meet us in the middle, or more than in the middle. They're very, very enthusiastic and engaged in care home work. But I'm going to take this even further and say, so that was open, as was optimal. We could encounter anything, and we stumbled into dementia. But even if you actively seek to look at something that's not dementia in care homes, and here's an example, the Falls in Care Homes trial, which is a large randomised controlled trial, just completed 1,800 care home residents across multiple centres in the UK, funded by NIHR HTA, ostensibly to look at falls prevention in care homes, and 67.2% of those enlisted in this trial had dementia, and most of those had moderate to severe dementia and didn't have the capacity to consent. So this trial, which is ostensibly about falls prevention, actually is about falls prevention in people with dementia. And if you look at all the process analysis that's coming out of this, it's about how to structure your falls prevention intervention, working with care home staff to take account of the fact that people have prominent cognitive impairment and often behavioural symptoms. So any research in care homes actually ends up being about dementia. And I'm not quite sure what that means. I'm just putting that there as a conversation starter for when we get to around the tables. This sort of work isn't possible without a decent sort of research infrastructure, and this brings me to Enrich. Enrich is a national scheme. John O'Brien is going to talk about it in its more generic sense a little bit later, but I wanted to give you a flavour of how we use Enrich in Nottinghamshire and Derby. And what we've decided to do is to build a community, a kind of family around research, and we have these Enrich forums that run 3 times a year. Each one will be focused on a research topic, so it may be around dementia or behaviour or falls. We have a research presentation, but then we have some fun interactive sessions. So, you know, when we have nutrition, we have a dysphagia chef come and prepare some food live as a catering demonstration. When we're talking about the arts and dementia, we have a soprano come to sing. And this has been about taking down the ivory towers that academics are seen to stand in and helping academics to learn about, well, I realise I didn't finish that sentence, helping academics to learn about the expertise in in care home staff and the actual expertise that's entrenched in the sector, and then allowing NHS staff to see this process of coming together and to participate in it. And we now have a very fertile and rich forum in Nottinghamshire. We have 80 to 100 attendees every time we hold one of these events. And just as an example of how it works, one of the enriched attendees has texted me during this meeting to ask for references for her master's essay. And we're not talking about a care home manager or owner here. We're talking about one of the care assistants that works in the care home. So that's how we've been able to take down these barriers. So enrich has been a really important part, and the research feeds the infrastructure, and the infrastructure feeds the research. We're taking that forward a bit, and I think this is part of an emerging sort of movement in different parts of the UK. So in Derbyshire, we have some funding from Health Education East Midlands to set up the Teaching and Research Care Home agenda, a Teaching and Research Care Home initiative, which is TORCH, and we're now in our second year of funding for that, and we're in the process of submitting a number of research bids, which have been dreamed up by the care home staff, and we have been told that we want person-centred care for people with dementia, and that's what they want to focus on. And this is based around a living lab model that we've imported from Maastricht in the Netherlands. Similar projects now emerging in Leeds through Niche, in Edinburgh through their Torch, and I think this is potentially the way forward, almost like a sort of enrich on steroids, where the care home staff have gone from being passive participants to active participants to leading it. And my final slide, just to get the conversation going, was I spoke earlier about the fertility of the NHS for care home research. This is an important part of the Ageing Well programme as a long-term plan, which is a framework for enhanced health and care homes. Dementia is very explicitly mentioned in that, and dementia care is very explicitly mentioned in that, but so is integrated care for older people. And that takes us to all the sorts of topics that I was talking on earlier in this talk. So an example of how this is going from strength to strength and maturing as a research sector, how it all subtends dementia, and how the opportunities now, I think, are larger than ever. I'll stop there.
Alistair, do I see you at the back there? Well, you're going to have to wait, because Karen's going next. You've been put to the back of the class, but we've got a slot for you at the end. We're running very slightly over.
Okay. Morning, everybody. So, a good range of topics today, and what I'm going to be talking about for the next few minutes is specifically dementia in people with a learning disability, and looking specifically at things that might have changed over the past decade or so, where we are now in terms of research, support, interventions. And really, this has come from the known risk that many of you will already be aware of, the known risk of the increased prevalence of dementia in some people with learning disabilities, particularly Down syndrome. But I'll be talking more generally about learning disability through the session. And I wanted to really start us off by taking this term off the table. I think we need to stop talking about hard-to-reach groups. I think that conjures up kind of images of an inaccessible population, which is just not the case. And I think we need to take some responsibility for that, those of us in this room. Perhaps there are groups, particularly minority groups, who may be under-researched, but that's not the same thing, and this isn't something that we should be hiding behind. And certainly it's something that is being increasingly challenged by self-advocates with a learning disability as well. And I'll come on and talk a little bit about how we're doing that. Just to think about some context first, diagnosis of dementia in people with a learning disability is difficult and it's different. And I'm not going to say that it's not harder. We've moved on in terms of we now have a range of screening tools that are available, not consistently used, even within the same country, not consistently used. It does vary, and certainly not internationally. We're aware of the need for baseline assessments for people with Down syndrome at a much younger age, so to help monitor any change in health or circumstances as people do go through those 40s and 50s crucial decades. These changes that may be picked up through the baseline assessment might not be dementia, and that's important as well, that we're constantly looking for other things that are going on. But this particular project here, that you see some of the images from, this is a 3-year project that's just coming to an end, funded by the Alzheimer Society. And we looked at psychosocial interventions, people who had a learning disability and dementia. But crucially, we also had an inclusive research team. So our research team was made up of co-researchers who have a learning disability. Not dementia, they have a learning disability. So we had separately participants and researchers with a learning disability in the study. So it was really important in terms of accessibility, communication, all the things that we should be doing anyway. We really had to make sure that we absolutely did. And we were told if we didn't, that's for sure. And rightly so. So the kind of strategies we used, the pictorial, the traffic light, but things we learned, that yes, involvement in the process is really important. And for us, some of the team were involved from literally the start of the funding application, where the funding application came from, the rationale for it. Others were involved at a more later stage, depending on where in Scotland we were going to be collecting data. So we had to be realistic about it. And that's important in terms of planning as well, and who's involved at what stage. Training was crucial. We had to make sure, so our co-researchers in the team conducted photo voice methodology. So that was an extensive period of training for them. And also training in the roles of the advisory committee. That was crucial as well. So our roles and responsibilities throughout the team didn't have to be the same. And why should they? That's standard in any research team, even when it comes to things like the dissemination, the writing, the publication. Everyone had their own roles and part they played in that, and that's absolutely fine. But I think crucial that we allowed more time for the work to happen and budgets. And I think it's certainly a shift has been that funders are certainly receptive to this as well, and acknowledging that actually we need to build this in from the start. We need to build in appropriate budgets and appropriate amounts of time so that this can actually happen. And just to jump us forward to last summer, this was an international learning disability conference where some of our team presented both oral and poster presentations. I have to say, a limited number of people with a learning disability presenting at a learning disability conference, which was a bit disappointing, and that's an area I think that we need to work on. But certainly our co-researchers shared their experiences, including one who was actually diagnosed with dementia himself during the process of the study. And that's something he now talks about openly himself in terms of advocating for not just himself, but for other people with a learning disability as well. And in terms of influence that we might have had and changes we might have made over the past few years or decade, I think we're gradually spreading the word. Jenny's Diary was a resource published through a dissemination grant at the Alzheimer Society a few years ago now, 2015. And this is a pictorial guide to supporting conversations about dementia with people who have a learning disability. And it now has multiple translations. And those translations have helped us to make inroads in other countries, in training, and in national plans or dementia strategies, depending on which country you're in. And I think we've moved to a certain extent to say that learning disability and dementia is now mentioned in dementia strategies, but we haven't really gone much further than that. And I don't think mention of the risk association is enough, and perhaps what people would expect from a strategy. So I think there's more to be done in terms of future strategies, future national plans, not just in the UK, but beyond as well. And just to bring us finally right up to date, we're now in the stage of organising a conference. We've got people with a learning disability organising a dementia conference for other people with a learning disability. Now that's happening next month at Stirling, at the university. It's not a plug because it's fully booked already, even with international delegates attending, just coming over for this conference. And I think even if we reflect, certainly this shows us the importance of respecting the authority of people with a learning disability as co-researchers, but it also, we need to reflect on the growing number of people with a learning disability who are affected by dementia, whether that's through a diagnosis in themselves, family member, friend, or a partner. And I think that's an important message to keep hold of. Thank you.
Alistair, where are you? If you just talk amongst yourselves while Alistair makes his way down, I think after this session it's going to be 3 questions will be put up on the screen for table discussions. Alistair, well done. You've got to hold it by your chin. And you've got 6 minutes.
Okay, thanks very much. I've often wanted to be described as the late Alistair Burns, so this is a good example. I think I did have a couple of slides, but they seem to have disappeared. This is the organisers' way of getting back at me, but that's fine. I think there's 5 things that I'd like just to talk about in terms of one of the specific questions was how research has, oh, there they are, fantastic, how research has influenced and perhaps changed policy. And really through the lens of the things that I think people are familiar with, which has been talked about, the well-being pathway, preventing well, diagnosing well, supporting well, living well, and dying well. And I'll just choose from each of these, if I may, one example of them. This is going very well. Yep. We look through the lens of NICE, and one of the issues with the NHS and with NHS England is we are guided by what NICE say in terms of initiatives. If we look at the example of prevention, at the top right is the NHS health check. Now, a few years ago, it was a real challenge to get dementia as part of the NHS health check because of the sensitivity of it being the most feared illness in people over the age of 50, and the sensitivity that we might be talked about screening for dementia. But dementia is now in the health check, and it's thanks to a lot of the work that's been done, for example, from Jill Livingston in the Lancet Commission. So that's an example of where some of the evidence, I think, about the risk factors, and essentially it's the soundbite, what's good for your heart's good for your head, I think has been extremely important. The second is about diagnosing well, and one of the successes that we know we've had is to increase the diagnosis rate across England. When we started in 2010-11, it was going about 40%. It's now about 68%. And I think that's an example where I'm not sure if we needed evidence that making a diagnosis was a good thing. We certainly needed some testimonials from individuals to say that a diagnosis was crucial. But in terms of the evidence that a diagnosis is a good thing was perhaps lacking. One of the issues we had was, should we talk about early diagnosis or a timely diagnosis? And I know there's lots of interest now, from example, from Shubhi Banerjee and Louise and colleagues, looking at exactly the implication of the diagnosis for an individual. And the example at the bottom right is Diaden, an app that can look at diagnosis. The third was looking at supporting and carers, and I think the best example here was looking at the reduction of the use of antipsychotic medication. From Shubhi Banerjee's report in 2009, based on the evidence that showed that 180,000 people with dementia prescribed an antipsychotic, probably in 2/3 it wasn't effective, 1,800 excess deaths and 1,600 excess strokes a year as a result of that. And that was crucial in achieving a 50% reduction in the use of antipsychotic medication. Next is living well with dementia, and many people in the room have pioneered the issue of dementia friends. From a standing start in 2011-12, there are now 3 million. And again, looking at the evidence as to whether dementia friends are a good thing or not, it's often retrospective. So the model is now, how can we show the difference that being a dementia-friendly care home, being a dementia-friendly hospital, for example, can make? And I think that's another example of where the evidence is important. And finally, end-of-life care. We published a document, My Future Wishes, with many people involved in the room, just looking specifically at what some of the issues are at end-of-life care. And again, that's probably something that we were a little slow in terms of looking at a number of strategies, but now dementia being the commonest cause of death in England, that's important. So in terms of the 5 issues, I think there are 3 points. We know the link, in my experience, between research and policy and clinical practice is rather, it's not straightforward. We all know about the length of time. It's not straightforward. Some of the times the evidence predates what we do. Some of the times it goes alongside, for example, with prevention. And some of the times it's actually evidence that we get after the event. I think sometimes we can't wait for evidence, and I think looking at prevention of dementia is important. There are lots of things that we can do about prevention that we know work, rather than waiting for a definitive trial. And the final thing, and I think the importance of the meeting today, is that message going out that care for people with dementia is complex. It's not like a new medication where a randomized controlled trial can be done relatively easily, although there are very good examples today. And so clearly that complexity, I think, is reflected in the discussions that we're having today. Thank you very much.
Alistair, thanks very much, and thank you to all the speakers and for keeping to time. So I understand now there's going to be some questions will appear on the screen or on your tables, and we have 15, 20 minutes, and then James will ring the bell for the coffee break at the appropriate time. So happy discussions.